Alrighty, we'll go ahead and jump right in here. Last off talking, I was finished up chapter 8. Uh, like I said, make sure you guys review those microorganisms and the diseases that they cause. Today we're going to go over chapter 20, case planning and kind of the interop routines, kind of things that we do in the OR. A lot of this you guys have already kind of done in lab, as far as like picking your cases and uh, opening your fields and strategizing, where to open things at and equipment and stuff that you need. But this will get a little bit more in detail about that. Um, the whole reason behind case planning is so that we can kind of get in our heads what we're going to be doing and kind of get a flow down of what's happening. Even if it's a case that you've never done before, you kind of stick to that big picture that I talked about a few weeks back in lab, where every surgery you're entering into the body somehow, either that making an incision, going through already a natural opening, something like that. You're going to have to dissect down to whatever it is we're going to be working on. We're going to need some kind of retractors for visualization. And then once we actually see what we're going to be working on, we'll actually do the procedure, whether we're removing something, repairing something, transpositioning, or moving a structure from one place to another, kind of thing. Whatever it is we're doing, then we do that part of the case. Then we always have to wash them out, or wash out the wound, dry it up, and then make sure there's no bleeders, things like that, and then close it up. So every case is going to go in that kind of order. Some kind of things to understand here, because of the different types of surgeries that we're going to be doing, right? There's, amputation, where we're going to be removing like a limb or like a digit, a finger or a toe or something like that. Anastomose or anastomosis, that's the bringing together of two hollow structures. So like a blood vessel that you transect, you cut, you need to bring it back together so that blood can flow through. You're anastomosing those ends of the blood vessels. Same thing with the bowel. If you have to do what's called a resection, take out a piece of that bowel, then the two ends that are left, you need to bring them together. So you need to anastomose those ends. Approximation, this is a term that we use for like suturing. That's we're bringing those skin edges together. This is all about bringing edges together. Don't get it confused with anastomosing, where we're bringing together hollow structures. Approximation is bringing together edges. Blunt dissection. This is how we can separate tissues without using anything sharp. We don't actually like cut through something. We're just going to kind of spread the tissues and push tissues off of other, like fatty tissue, like subcutaneous tissues, things like that. We can push those off of the underlying structures that are beneath them, like the muscle and things like that. We can actually just kind of scrape them off almost. Debridement. This is taking away like dead tissue. We're removing that kind of stuff. We can use, scissors to cut it away. We can use a knife. We can use curettes. Those are little kind of spoon-shaped instruments that we have. Mainly, curettes get used on bone most often, but we can use it to scrape away dead, non-viable tissue that's in a wound. Usually the debridement is saved, for those patients who have like some kind of abscess or infected wound or something like that, or an open wound that's infected or not healing, things like that. We're going in there just cleaning away all that dead tissue, so the healthy tissue underneath can come back and try to repair that area. A dog ear, it's like when you dog ear a page on a book or something like that to mark your page. It looks the same. It's when you're suturing the skin, and because you didn't place the sutures correctly, this is going to be the surgeon who's doing this. You end up in the edges or the corners of the the incision site with this little dog ear that pops up, and it kind of stands up. So it's kind of an ugly looking thing, and they may cut away some of that excess skin in order to get it to lay flat. Debulking. This is mainly with tumors and with like cancerous tissue and things like that. The tumor itself is big, so you're going to take pieces of it and bring it down to size. That's what debulking is that you're reducing the size of that tumor. Sometimes we have to do this in surgery, either in order to remove the tumor, we debulk it, we cut it down to size, or if the tumor has kind of like wrapped itself around major blood vessels and things like that, to where going in and taking out the tumor completely is actually going to cause more harm to the patient than good. So they'll debulk the tumor, take it down to as small a size as they can, and then they'll use radiation treatments on the patient, and chemotherapy and things like that, to try and destroy the remainder that was left behind. Dissection, or to dissect, you're separating anatomical structures, because even though you see it like in the books and in pictures and things like that, everything looks like it's all separated from one another. Actually, there's tissue stacked on top of tissue, so there could be like fatty tissue wrapped around like the common bile duct or cystic duct when you're doing a gallbladder removal or things like that, and you need to dissect those things off of those other structures first so that you can expose them and get in there and put your clips on and make your cuts and things like that without damaging any other tissue. Elevate, right? This is a technique that they use to kind of lift tissues and things off of other tissues. Most often, the instruments that we use are actually called elevators. Mainly, you'll see them used in orthopedics and also in ENT when they're working in the nose. But in orthopedics, you have what's called a periosteal elevator. On the outside of your bone, there's a thin, kind of fibrous, dense tissue called the periosteum. And if you're dealing with like fractures and things like that, you need to get that periosteum off the bone so you can put your plates and screws and your fixation devices directly on the bone. Excise, this is taking out tissue. Right? You're actually cutting it out. Exposure, right? We talked about that with using retraction or retractors and everything like that. It allows us to see actually what we're working on. Right? Exteriorize, that means to bring like tissue or an organ or something that lives inside the body to the outside. We do this when we're working on the bowel. We'll bring it out of the abdomen and actually set it on the drapes and things like that, so it's out in front of us and we can see it better and things like that. We're not working down in a cave and stuff. Ligate, this is to constrict something by tying it off, tying a suture on it. Most often we ligate blood vessels, but you can ligate any tissue because you're just putting a suture or some kind of suture material. It can be a free tie, it can be one with a needle on it, something like that, but you're constricting off of the blood flow by putting a suture around it and tying it down. Resection, or to resect, I talked about this when you're taking out just a piece of tissue. You can resect the colon, you can resect the stomach, you can resect the liver, you can take half of the liver out. You can resect the pancreas, just take a piece of the pancreas out. We can always take just a piece of something and then work on getting uh, the normal function and everything back by, putting other structures back together and stuff like that. Undermining, this is typically the skin. So let's say that we're going in and doing a procedure on someone who's had previous surgery in that area. For this example, we'll say the abdomen. Patients had previous abdominal surgeries, so they have a pretty good scar going down the middle. Well, the surgeon decides that they want to excise that scar, but in taking out that scar, you've lessened the amount of skin that you can bring, to approximate those edges when you're trying to close at the end of the procedure. And maybe it's too tight and those edges don't come back together. What you can do is undermine. So you're going to go just under like the dermis and separate it from the subq fat all the way along, and that kind of loosens that skin so you can get it to pull and get a little closer. And then visualize, right? You're seeing it in detail, right in your face. Visualization. But those are some of the common things you're going to hear in the OR, right? I've got a dog ear, or I need to approximate these edges, or let's start our anastomosis, things like that, so that you kind of understand what's being said and what they're trying to accomplish. Case planning, it's not a mandatory thing. You don't have to do it, but you're going to be real lost if you don't, especially early on. It helps with this case planning thing, kind of helps you to organize what you're going to do and in what order you're going to do it, right? Like, am I going to open my back table first, or am I going to open my instrument tray first? Do I need to, load up these sutures, or do I need to organize my draping first? Right. This is where prioritization comes in, and you understanding what has to be done before something else can be done. Right. Like the patient has to be prepped and draped before we can bring our Mayo stand up to the field. Right. Kind of things like that. These are kind of the elements of a case plan, right? That's the name of the procedure, right? What are we doing? What type of procedure is it? Which means what service does it fall under? Is it an orthopedic case? Is it a general surgery case, a GYN, urology, plastics? Those are things that are going to start giving us clues into the instrumentation and the supplies that we need, equipment, positioning, that kind of stuff. What was the pre-op diagnosis? Right? Does it match the name of the procedure? What we're actually going to be doing? Do we need to notify the lab? Are we doing a breast biopsy and we may need to do a frozen section? So we have to notify the lab so that they have somebody available to be able to come and look at that specimen when we're ready. What's the patient's BMI? Right? Do we have the proper OR table? Depending on the position the patient is going in. Do we have the proper positioning equipment for a patient who has a larger BMI? Right? What's the patient's age? Are they a pediatric patient? Are they a geriatric patient? Right? That's going to play into, okay, if they're geriatric, maybe we need to get some more, paddings for bony prominences and things like that, because we know the skin to be a little bit more frail and things like that. If they're peds, do we need to? How much of a ped are they? Are they, infant? Are they school age? Are they adolescent? Right? Do we need a crib? Do we need a gurney? What's going on here? Do we need to put some kind of warming blanket on the bed prior to the patient coming in? Because they're such a small child, we need to keep them warm, those kind of things. Does the patient have some kind of mobility issue? right? Are they a little older? Maybe their joints, maybe they have some kind of contracture in their arm or their leg or something like that. They can't really move themselves, right? That's going to play into, okay, do we need a roller? Do we need one of the hover mats? That kind of thing. Is the patient, hard of hearing, blind, all those kinds of things, so that then we can get things in order to help move them over and to be able to talk to them, things like that, right? Where are we making our incision, right? That's going to help us with our positionings and things like that. What kind of skin prep, right? Is the patient allergic to shellfish? Oh, we know this doctor says he wants betadine prep for every case, but this patient's allergic to shellfish, so we can't. So let's, and that betadine kit would have been picked for that case because that's what that surgeon wants. That's what's on their preference card. But we may have to switch it a little bit because the patient can have it. So we would know to get rid of that one and go get an alcohol based. Right? What kind of drapes? Right? What are we working on? Are we working on a limb? Are we working on an abdomen, a breast, the head? Right? It's going to change up, the draping and stuff that we need. What kind of instruments do we need? Is there any imaging required? Do we need X-ray? Right? Are we doing like a bone fracture or something like that? Then we would need the C-arm. We have to let radiology know. Do we need any kind of other equipment? Are we using air-powered drills? Are we using a battery-powered drill? Are we using like a burr or something like that? Um, are we bringing in, do they want a different kind of bovie, like the argon beam coagulator, or regular bovie going to be fine? These kinds of things that we need to bring in. Are there going to be any implants put in? Right, if we're fixing a fractured bone, then we're definitely putting implants in. Right, do we need to have the trays, the instrumentation in order to put that kind of stuff in? If we're doing a total joint replacement, yes, we're putting implants in. Are we doing a mastectomy with a breast reconstruction? So yes, we're putting in breast implants after we've removed the cancerous breast tissue. Right? Do we need to? What kind of suture are we going to be using? Right? What kind of tissue are we working on? That's going to lead us into our sutures. Right? And then we can even curtail it more by paying attention to the surgeon's preference card and knowing certain sutures and things like that are listed on there that they prefer. Right? Are we going to be putting any drains in at the end? Right? What kind of dressings might we need for this particular wound, right, or this particular surgeon? Where's the patient going after we're done? Most of them are going to go to PACU, but some are going to go to the ICU. The discharge one here, most patients, if they're going to get discharged after surgery, it'll happen from the PACU. So we won't deal with anything like that in the actual operating room. But we could have patients who are being discharged and going straight home, especially if they had their surgery done under like a local anesthesia. They'll take them over to PACU so that they can do the paperwork and they can make sure that the patient's okay before they discharge them out. But usually they're not in PACU, but maybe 30 minutes tops, and then they're sent home with whoever was there to help take them home. Your case plan is going to take your knowledge of a procedure, which you guys at this point have, probably your greatest knowledge right now is on breast biopsy. Right? But then also with surgical techniques. So are we removing? Are we repairing? Right? Is this just diagnostic? And so here's your categories, right? If it's just diagnostic, that just means we're going in and looking. So we probably won't need any kind of implants. We're not going to be removing anything. We're not going to be repairing anything. We're just looking. Now, most of the time, you'll see a surgery booked. It'll say like a diagnostic laparoscopy with possible, and that's what'll happen is it'll start diagnostic, but because they have all these possible things behind it, then depending on what you see when you get in and look, then the decision is made on what to repair or to remove or to maybe not do anything at all. Typically, those are called peek and shriek, where you like look into the abdomen, you see something that's very, really, really bad, like they're just riddled with cancer and nothing that we're going to do surgically is really going to cure them. It's just going to hurt them. Then they abort the case right then and they take all the instruments out, close them back up, and then go have a conversation with the family and stuff about what they found. Um, we could be doing a reconstruction or putting in an implant, something like that, right? Uh, we could be repairing like a ruptured tendon or torn muscle, things like that. And we could also be removing an organ or tissue, something along those lines, like a debridement, things like that. Some questions to kind of ask yourself in the diagnostic, right? What are we going to look at, right? Are we doing a colonoscopy? Are we doing a laparoscopy? Colonoscopy, we're going to go up from below with a scope and look, throughout the colon, making sure that it looks okay. Patient's been complaining of like constipation or pain or something like that, and they'll go up in there and look. They could be having, abdominal pain. They've done CT scans and MRIs and things like that, and they're not seeing anything that's a problem, but the patient is still having pain, so they're going to put a scope in the abdomen and take a look around down in the pelvis and all the organs and stuff like that, and see if there's something that they can't now, visually see with their eyes, that there's a problem. What special equipment is needed, right? Are we doing this through scope? So then we need all the laparoscopy stuff, or the scope tower and the cameras and the light cords and all that stuff, or are we actually going to open this patient up and look? Right? Are we going to be taking any tissue samples and sending them off for specimen? Maybe there's some things I need to, like some extra cups and things like that, to have on my field so that I can put these specimens into these cups and pass them off. Right? How are we documenting all this? Right? That may go in playing as to the information we need to know to be able to tell our circulator so they can get it down on the documentation. Are we going to be doing it in the actual operating room? Are we going to like a special procedure room? So like if you're doing a colonoscopy, you'll be in the endoscopy department, which is usually like right next door to the OR. Were there any previously like X-rays or MRIs, CT scans that were done that we can have a copy of these and hang them up in the room in the X-ray boxes so that the surgeon can come and look at them prior to surgery and get one last look and be like, okay, and kind of refresh their memory about this particular patient and what they're looking for. Kind of thing. And then what kind of anesthesia is this patient going to be under? Are they going general, local, monitored sedation? Like, I mean, because that's going to play into, maybe some positioning aid things. We have to be aware that the patient may be awake, and there's certain things we may not, want to say out in front, while we're working and things like that. If it's reconstructive, right, same kind of questions. Right? What kind of instruments are we going to be using? What are we actually reconstructing? Right? What position are we going to be put in? Are we going to take any grafts from that patient? Right? If we're repairing an ACL, we may take the middle third of the patella tendon or we may take a little bit of the hamstring and use that as the graft. If we're working on the wrist, like there's a wrist fracture or something like that, we have to take some bone out, we may take a piece of the iliac crest as bone graft to replace what we removed. So, and that may change, because not only now do we have to prep that arm, but we also have to prep out that hip if we're going to take some bone from it. And we'll do all that before we drape. So, are we going to have to drape out multiple sites because we're taking a graft from somewhere, right? The autograft means taking it from that patient. It means it came from self, like autobiography. You wrote your own story. Autograft is we're taking that graft from that patient. What's the patient's age? If they're, a pediatric patient and we're working on their bone, we have to be very aware of the growth plate. Because if we interrupt that growth plate, then that bone is going to stop growing at that spot. And that may, shorten a leg or an arm or something like that because they haven't fully developed. Does the reconstruction require some kind of external support? Like, are we going to put a cast or a splint on afterwards? Let's make sure that the cast cart is nearby the room, so at the end we can just wheel it in and use it. Right? If we're putting in implants, are there trial sizers? Right? Where are those trial sizers? In orthopedics, they're in our trays. They get opened, but in like plastics and things like that, like for breast reconstructions, you may not have a trial sizer, right? You may just grab a few different sizes of implant, and then now the surgeon has a choice, and they can be like, let me have the 500 cc ones or the 250 cc ones, something like that, right? So that because they're trying to match it to the other side, so that you get that symmetry. Repairing. What are we repairing? Right? Does the patient have like a deviated septum? Do they have a torn Achilles tendon? Do they have ruptured bowel? Right? Do they have a ruptured aneurysm? Right? Do we need special instruments? Right? Depends on the surgery, the service. Right? Or is it vascular, ortho, general? Right? Because that'll determine what types of instruments you want to go and grab. What are we going to use to make the repair? Are we going to be using mesh for like a hernia? If we're repairing a tendon, are we just going to use, heavy duty sutures? What are we using? Right? And it may be that you've never done that kind of case before, but that's the question that comes to mind. You may not be able to answer it yourself, but then you know what question to go and ask somebody else. How are we going to hold this repair in place? Is it going to be able to stay on its own? What techniques are we using? Is this whatever caused the injury in the first place? Is it related to a disease process? So how effective is this repair really going to be? Right? If it, like, for instance, ruptured bowel. If somebody's got like diverticulosis, diverticulum is like the little bumps along your bowel and things like that, but can become like inflamed and kind of swell up. And then you have fecal matter kind of going into those areas and getting trapped in there and not getting released. We go in and we do a resection because one of those ruptured. Well, you have multiples of those. So is this something that's going to happen again? Maybe there's something that we can do or talk about with this patient regarding their bowel health and things like that. And like in the repair, are you going to need x-ray? Is there going to be a possibility of a lot of blood loss? Right? If we anticipate we're going to be doing a procedure that we're going to lose a lot of blood off this patient, we may have blood replacements and things like that already on hold. Already called down to the blood bank and had them prepare them and have them ready to go, so that all we have to do is just call and say, hey, send them up. And we've already done all the paperwork and stuff like that. So we don't have to waste that time. Removal, right? What are we taking out? Right? What's near what we're taking out that we may have to deal with? Right? How are we going to go about getting at this? Are we going to do it minimally invasive? Are we going to open? What's going on? Is that item that we're taking out going for a frozen section? Right? Do we have a pathologist ready to come and read that then? Right? Is the wound contaminated? And it can be, we can have intact skin and still have a contaminated wound because of like ruptured bowel and things like that. We have bacteria and microbes and things that don't normally live inside the abdominal cavity now spread out with inside of it. So that would be considered contaminated. Um, if we're taking something like a bullet or something out of a patient, what special procedures do we need to follow for the police, right? And the forensics, right? Can we handle that bullet fragment with metal instruments? No, by the way, because what can end up happening is that we put scratches on that bullet, and that changes its ballistics, because every gun has a very specific mark that it leaves on the bullet fragment, and you can match that up to the gun that it was fired from. But if we're handling that bullet fragment with metal instruments, or we're even dropping it into like a metal bucket or metal bowl, then that can cause like a little dent or scrape or something in that's not going to match it to that gun. So that now that person in a court of law can say, I didn't fire that bullet. It doesn't match. The surgeon's preference card, right? You've all have seen one in the lab, right? And it's got all of this kind of stuff on their preference cards. This is the idiosyncrasies. Most of the time, you're really not going to find a whole lot on these, except maybe like whether they're right or left-handed. Most of the idiosyncrasies you're going to get from your fellow coworkers. Oh, you're working with Dr. So-and-so today? Oh, make sure you've got this, or make sure you don't do that, or that kind of thing. But it has all this stuff listed on your preference card, and then you check your preference card versus the supplies that were picked for it to make sure you have everything that you need, right? And sometimes your preference card doesn't match what it is that you're actually doing, because they're supposed to have a preference card for every surgery that surgeon does. Sometimes they bring one in that's just kind of an off-the-wall surgery that's not a typical type thing that they do often. So they may not have a card specific to them, but you can find one from another surgeon and just kind of use that as a guide. And then, and doing the procedure and asking questions of the surgeon and what they want and things like that, you can kind of update that card and then give it to the person who's in charge of that service. And then they can create a preference card for that surgeon for that particular case. So one of the first things we do when we walk in the room is we get the non-sterile stuff ready, right? We arrange our furniture. We, make sure that our back table isn't right up against the wall. We kind of pull it away a little bit. We give a little bit of space for the Mayo stand from the back table, and the ring stand and the double ring stand. We do our wipe down, right? We make sure that there's clean linen on the table, that the suction works, your suction tree works, right? That your Bovie turns on, whatever other equipment that you're going to have in there, as far as like if you have like a nitrogen tank for gas powered power tools, or your laparoscopy stuff. You're checking your CO2 canisters, making sure you've got enough in there to last the case, and all that kind of stuff. You're just looking over all your non-sterile stuff, making sure it's in working order, and that it's kind of arranged and set up, ready for you to kind of lay your stuff out and open. Typically, this is a circulator and scrub responsibility, is preparing the room beforehand. You're grabbing the like CT scans or the MRIs and things that the patient has had done, and hanging those up on the X-ray boxes, all that kind of stuff. Just kind of generally getting the room ready. When you're opening, right? You've all practiced this. You keep that safe distance at least 12 inches away, right? Put your trash in your trash cans. You don't peel the tape off. You just break it right where the fold is when you open it. That's to prevent you from ripping the wrap when you peel the tape. Make sure if you're going to open up something that is wrapped inside of another package, that you're going to open that package, you're going to reach in and take out the thing that's wrapped, throw the package away, and then unwrap that item and throw it up onto your field. You never just open up the package and drop the thing still in its wrapper onto the field. It's not considered contamination because the thing inside the package is still sterile. It's just bad practice, very bad practice. And we don't want to see you guys doing any of that kind of stuff. If you've got like a heavy item, heavy instrument tray, or a heavy wrapped tray, put that on like your ring stand or like a prep stand or something like that. Don't try to hold those and open them onto the field. More often than not, you're going to drop it or contaminate it in some way. Do you guys know how to open up your containers, right? You pop the lid and you lift towards yourself, take that step back. Right? If there's something that says have available or hold on the preference card, you do not open those items, but you just keep them in the room in case they're needed. Definitely open your sharps during when you are opening. There's been some recommendation about opening sharps after someone has gotten scrubbed in to prevent them from like sticking into the back table cover, or somebody getting cut or something because they're just kind of open by themselves and free. But as long as you're opening onto that like corner and you're not throwing anything else down on top of them, it's much better to have that stuff open, because you don't always have somebody helping you open. Your nurse is not just standing there waiting for you to open, get scrubbed in so they can tie you up and pour you your meds and count with you and all that stuff. They're off doing their own thing. They're either finishing up from the previous case, or they're going and interviewing the next patient, or they're running and grabbing something for anesthesia. People are always doing something. So you may be completely alone. And since your blade is something that you need, one of the first things after you've draped and all that stuff, you don't have time to be waiting for somebody to open it to you. And then you never, ever, ever, ever gown and glove yourself from your back table. You're always either opening it up on the Mayo stand or on some other flat surface in the room. I would not recommend doing it on the OR table itself, because sometimes you're still at the sink scrubbing and they come wheeling in with the patient. And if your gown and gloves are opened on the OR table, now that patient doesn't have anywhere to go. And you have to hope, somebody takes your gown and gloves and moves them, that they did it aseptically without contaminating them. And you have no idea of knowing. You'd have to trust that someone did it right. So our intraoperative sequence, right? And you guys have been going through this. And again, the earliest that any class has been scrubbed in since I've been there. So kudos to all of you. You guys are picking this up pretty quick. And now it's just going to be a matter of repetition, doing it over and over again until it becomes like a second nature. But, you did all your opening, you went and scrubbed, you gown and glove and immediately set up your field, do your first count, then they give anesthesia to the patient. Your circulator can give you up any additional stuff that you needed, or maybe there was something that was on hold and you didn't get a chance to talk to the surgeon, and now they come into the room while anesthesia is doing their thing, and they're like, "Oh yeah, I'm going to need all that stuff or whatever," and then now you can tell the circulator, "Hey, can you go ahead and open me, all this stuff here in the pile, or just open me up that and this, and then the rest we can get later or whatever." Uh, then we position the patient, prep them, drape them. We move all of our sterile tables into position, starting with the Mayo stand, right? Then we bring our table over and our ring stand. We pass off the suction cords, the Bovie cords, secure those cords. We throw some sponges up on the field, and then we do a timeout. Talk about who the patient is, what we're doing, right? What their allergies are, what their blood pressure is. We make sure that if there are implants and all that, that they're there and available, ready, and that everybody agrees. Because during the timeout, everyone stops what they are doing. There is you're not still throwing cords off. Everyone has to stop and listen to what's being said, so that we're all on the same page as to what's going on, who we're working on, what we're doing, and that we're all in agreement. And then we can go ahead and continue with the procedure. As soon as surgery is started, usually the surgeon will say, like, incision or something like that, so that the nurse can look up at the clock and mark down the time that surgery started. And then we're working with the surgeon, right, watching them, anticipating their needs, right? And once we're done doing our part of the procedure and stuff like that, we start closing. Then we do our counts. We're passing off our specimens, things like that. Finally, the wound is closed. We take the patient goes through emergence now. I remember they were in induction when we were giving them the anesthesia, while we were anticipating the surgeon's needs and making the incision and all that. They were on maintenance. Now they're coming to emergence. They're waking up, right? We're putting the dressings on. We're taking the drapes off. The patient gets moved over to the gurney and then goes into their final phase of anesthesia recovery over in the recovery room, right? My advice for like doing your setups and things like that is come with a very methodical approach. Make yourself a list of the order you're going to open things, and try to stick to the rules, right? You have to open up your back table cover first and then move out, that you don't want to end up with a non-sterile field in between two sterile fields, right? But make yourself a list and write it down and go over it, and even try to study that list, and then take that list and turn it over, or put it away, and then try to rewrite that list again without looking at it, so that you have your steps down of what you're going to do. Because a methodical approach will improve your efficiency and greatly, greatly reduce your stress. Because if you already have a system of what you do every time you come to that table, every time you go to open, all right, I'm opening this, I'm opening that, I'm opening this, and then I'm going to start opening my stuff onto this table. And I'm going to open this drape here, and I'm going to open this gown here, and these gloves here, and these towels over here. I'm going to open up my sponges over here and my blade. And then when I get scrubbed in, the first thing I always touch is, this stuff. And then I organize this, and then I go and grab my tray and bring it over. I'm always doing the same thing every time, so that you're going to get faster. You're going to get more efficient at it, because you're just going to get used to it. You're going to start doing it without even thinking. And before you know it, your setup is done. We had somebody today. She set up her Mayo stand. She was going through her categories. She was asking herself the right questions. She was putting everything she thought she needed up there. I came over and I checked it, and I was like, okay, good, good to go. She's like, really? Hmm. I felt like I was forgetting something, but I guess not. And that's kind of the feeling you'll have that first few times that you do it without really thinking about it. That you just kind of do it because you're already used to it all. You'll be like, there's got to be something I'm missing. That felt too easy. There's something I'm missing, but there probably isn't. It's just you're getting better. That is all. uh, One of the first things that you should do when you get scrubbed in is drape out your mayo stand, because now you're increasing the size of the sterile areas. So if you have a bunch of, supplies and equipment or, trays and stuff like that, you now have another sterile place where you can kind of put some things to kind of get them out of your way while you're doing your setup. Be sure to check all of your sterilization indicators as you open things, right? You're kind of looking into the tray, making sure that you see it, or even before you're putting it on your field, you're verifying that you see the indicator and that it is changed. Because there's nothing worse than just finishing your setup only to find out that the instruments you put up there weren't actually sterile and your entire setup is trash. So avoid shifting things, right? If you're going to touch something, grab it, put it where it goes, leave it alone. You don't need a whole lot of, fine tuning or, taking one item and putting it here and then 5 minutes later coming back and grabbing it and moving it 2 inches to the right. And then coming back another 5 minutes and going, I like it better over here 2 inches to the left. Like, put it where it goes, leave it there. Don't try to do too many things at the same time. Right? You don't try to be grabbing out your bovie and your suction and all that stuff out of the basin at the same time you're trying to throw instruments up on the mayo stand, because you're going to be kind of caught up and discombobulated as to what exactly it is that you're doing. Right? And then definitely start prioritizing those things you're going to need first. Start thinking about how these breast biopsies have been going. Right? What's the very first thing you need? My gown and gloves. Right? After I get gown and gloved, what is the next thing that we do? Drape the patient. After we've draped the patient, what are we doing? Putting the light handles on, right? Passing off our cords, right? Doing our timeout. What's the very first thing I need after timeout? The local. So you get that ready. So you get my gown and gloves ready. You get the drape ready, right? And that's part of you organizing that area when you put it there. Grabbing those stack of towels, grab 4 off of it. You have all that room right in the beginning, right? You don't have any instruments up there, nothing kind of getting in your way. Make your 4 towels real quick, fold them up, boom, throw them on top of the drape. That's now done. Drape your mayo stand, take care of the towel, cover your mayo stand. Right? Then go and grab your instruments, bring them up to the field, and grab your basin. Grab that whole basin, bring it over to the table, and then start taking stuff out of it and putting where it goes, and then put the basin back in the ring stand. Right? And when I say take the basin, just the basin, leave the drape there. Right? The wrap that it was in that you unwrapped it from, just pull the basin out, and then you can put that basin back onto that wrap, because it's all still sterile. And now everything's all set up. You're not having to walk back and forth to do it. Right? Then ask for your meds while you're pulling your stringer out and everything, so your nurse can go over and get all that stuff prepared, and then you're pulling out your pitcher and your cup so that you can get that local loaded up in the syringe and everything labeled, your hypo on, and then right after the local, I need the knife, right? What I've been seeing, and we haven't really talked about it yet, is that everybody waits until they're completely done with their setups and counts to load their knife blade. That should be one of the very first things that you do, because what happens if something happens to that patient during induction of anesthesia? And now we have an emergency going on and we need to put in a trach. They don't have time for you to wait because, and now it's an even more stressful situation. People are like, come on, I need a knife. Let's go. Give me a knife. And you're trying to load up. So it should be after you get your instruments on the field, you get those knife handles. One of the very first things you should do is load that knife blade. Now I know some of you might be thinking, but we can't take our stringer off of our instruments until after we've counted. It's more of a prioritization to have that blade loaded and ready than it is. You can take that stringer off, just don't put anything up on your Mayo stand yet until you've done your count. Oh, prior to preparation. Oh, look, I just went over all this stuff. All right, your starting instruments, that would be your knife, your local, things like that. Retractors, your met scissors, right? Get some sponges up there. If there's some sutures that you know are going to get used intraoperatively, like we're marking a specimen, you can load that suture on the needle driver and just leave it on the back table ready to go. That way, when they're ready for it, they're not waiting for you to load as well. It's already there. You just have to pick it up and hand it to them. Right? So once you have all your priority stuff, all those things you're going to use like first off, ready to go, everything else becomes kind of secondary. This is you kind of tweaking your little things or laying out your forceps just like you like them, that kind of stuff. Right? Arranging your needle book, just right so everything's at like right angles to one another. Hey, however you want to do your setup is how you want to do your setup. But prioritizing those things and getting those things done first, they're going to be needed first, is going to go a long way in your efficiency and reducing your stress. Because your stress will really shoot up if they ask for something that they need early on, but you're not ready for it. And then you'll start hearing the questions of, oh, you didn't know we were going to cut this patient? Or why don't you have that ready? Or, is this your first time ever doing this? That kind of stuff. But if you could think about what's always needed at the beginning of every surgery, then you can always have that stuff ready. And then you can play with it. Like there may be an instrument set on your field full of instruments you've never seen before. And once you have all your priority stuff ready, that gives you that time to kind of play with these new instruments, see how they go together, see how, inspect them and look at them and be like, well, what category might I place this one in? Does it look like a scissor? Does it look like something that would grasp and hold? Those kinds of sutures. Right? We've been playing with the ties, doing the breast biopsies. The way that you guys have been handing them to me right now, that's what's known as a free tie. A tie on a pass, you're going to load it onto one of the instruments, usually the mixture or your tonsil. And I'll show you guys how to load those in lab. You also have what's called a reel. It's just like a little spool, and it's got one long string, one long suture on it. And you can use it over and over again and just cut it, and it shortens until you've run out of enough, and then you get a whole new reel. We talked about the swedged on needles. Those are the ones that the string doesn't just pop right off of the needle. And then your control release, these are the ones that are also known as pop off, where you can just snap that string right off the end of the needle, real easy. Doesn't really require a whole lot of strength. You just a good tug and it'll it'll come off pretty easily. I'll also show you guys how to make the suture book for your ties. It's where you can take one of your blue towels folded and leave it folded, and you can line because you may not just have one size of ties on your field. You may have multiple sizes, and this way you can keep them separated as to which ones are O, which ones are 2O, which ones are 3O, kind of thing. Instrumentation, right? This is the categories, right? Go by your categories. Think about what you would need and versus the tissue that we're working on, right? If you're trying to get something that's grasping and holding, are we grabbing onto something tubular? All right, gonna grab the Babcocks. Are we grabbing onto something that's heavy, dense type of tissue, bone or tendon or something like that? Then maybe the Coker. Uh, is it neither one of those? Is it not tubular, not heavy, but not really like kind of delicate tissue either? Then maybe the Alice. um, Everybody's setup is different, right? There's certain hospitals that you may end up working at. I don't think there's any here in this area, but I have heard about them across the country they have their techs do what's known as a universal setup. Everybody sets up the same way every time, so that um, there's less chance for things getting lost, and it makes it an easier transition when you're getting relieved for like lunch or at the end of the day. Somebody's not coming in and having to figure out where you put things in your setup. Um, I like the variability because I like to be able to do my own thing. I like to be able to do things that make sense to me, right? And I'm an old dog, so teaching me teaching me new tricks is not probably in the cards. Um, but you want to place your instruments in a very specific place, and once you do, however you make your setup, and however it makes sense to you, make sure you're doing it that same way every time. So if you put your atraumatic forceps on the right hand side of your tray and your traumatic ones on the left hand side of your tray, and you have your Adsons in the front and your rat tooth next, and then your big ones, behind that, like your Bonnie or something like that, behind that, then that's the way it gets lined up every time. And it makes your setup go faster, but then it also makes it super easy when they ask for one. You're just reaching over and heading for that general area and then grabbing the one that you need and coming back. You're not having to turn all the way to your table and scan it from left to right, top to bottom. Oh, where did I put that one thing? Right? And the same thing goes with your Mayo stand, right? Wherever you line those instruments up, when you first set up your Mayo stand, after you've given that instrument to the surgeon, they've used it and given it back to you or set it down on the patient, and you pick it up, you put it back in that same spot that you first put it. So that if they ask for it again, you're not now searching your Mayo stand for where did that instrument go. If you're ever in a position where you have multiple trays on your field and you need to stack trays on top of one another, put your heaviest one on the bottom so that you're not accidentally damaging any instrumentation by putting heavy instruments on top of light, delicate instruments. And you could be crushing things and bending things and damaging instruments. You don't want to be doing that kind of stuff. Right, your Mayo, your frequently used items. Right? Same thing as your back table. Everyone's setup is going to kind of be a little bit different. Right? You want to try and keep your sharps as close to you as possible. So think about what side of the table you're going to be standing on, where your Mayo stand is going to be, how it's going to come in, so that you can lay those things out so that your knife blade and your hypodermic needle, those kinds of things are always closest to you, so you can keep an eye on those sharps. Like I said, that standardized setup may be out there. Yeah, I haven't seen it here in Orlando, but it does exist. So, and then you want to try and keep your Mayo stand neat and clean. Right? Sometimes surgeons use an instrument, they take it when they're done with it and just throw it up on your Mayo stand randomly somewhere. You let it land, then you grab it, take it, put it back in its spot. Right? They throw a needle holder with a needle on there. You grab that needle holder with the needle, you immediately put that needle in the sponge part of your needle book. And then you can either put the needle holder, back into the where it goes on the stringer, or if you need another suture, you're loading up another suture with it and having it ready. You do not want your sharps to be hanging out on your Mayo stand any longer than is necessary. So what that means is that once we use the blade to cut skin, that knife should not be up on your Mayo stand. It should be back on your back table by your instruments or near your needle book so that it's safe and nobody can get cut with it. Same thing with the local and the hypodermic needle. As soon as the injection is done and it's handed back to you and you hand up the knife and they're making their incision, you're taking the hypodermic needle off, you're refilling that syringe back to 10, reloading the hypodermic needle, and then setting it down on your back table. Usually right next to, what will end up being right next to your knife blade. It's usually that right by the time you've reloaded that, put the hypo back on and set it down, they're putting the knife back on your Mayo stand and telling you knife on the Mayo. And then you're grabbing that blade, putting it over next to the local, and then coming back to the field. They're using sponges to, sop up a little bit of bleeding and probably the bovie to stop those little bleeders, and then cutting down further into where they need to go. They may need the scissors at that point, but then now you're already back up at the Mayo stand. Um, uh, being able to pass instruments. The question was asked that a suture that touches contaminated material would still be put back in the needle book. That's the question. So if the suture, like the string, hung down below your field and the string was contaminated, you would just cut the string and let that fall to the floor where it was contaminated at, but then you could put the needle back in. Now, if you, let's say, we were suturing something in the abdomen off of someone who had ruptured bowel, right? And there was fecal matter all inside. Yes, because you are putting that needle back in your needle book because there is no way to separate dirty from clean now because that patient was already dirty on the inside. With certain other procedures, like where the patient was sterile and we've actually entered and done a resection on the bowel, and now we're reanastomosing and we had to open the bowel up. Now those instruments that we use on that get wrapped up in like a towel and get separated and either laid in our basin or somewhere off the field. It all still gets kept and organized because we still have to count that stuff. But we will take those needles, and you guys have seen the way that I hand you back needles with that the sharp end protected. That's the way we will put those needles on a needle holder in with those other instruments, and it will still be counted. And that way, that sharp piece is protected from poking, like the nurse and stuff like that, but it's still there and it's not on our field contaminating anything else that we have. Um, Also, in some instances, you will have two separate setups. You will have a dirty table and a clean table. This is if you're doing something laparoscopic and you have to go down to a dirty area at the same time in the same procedure. That way, and you'll have all the same stuff like your needle book and everything, because sometimes you do have to have suture on the dirty table. Then you would put all of that into those dirty needle books, and all the dirty stuff would be on the dirty table, and all the clean, sterile stuff would be on the clean table. Uh, your irrigations, these can be given to you after the case has started. It doesn't, your irrigation doesn't have to be poured to you before we start. What does have to be poured to you before you start is your local, because you need it. But irrigation doesn't come until the end of the procedure. So sometimes you don't get it until you're close to the end, because we would like for that irrigation to still be warm when we use it, right? And your procedure could be like 3 or 4 hours long or something like that, and we poured it up at the very beginning of the case. The room is cold. By the time we get to the part where we're going to irrigate, that fluid is now cold. So we would have to discard that fluid, get rid of it, and then get new warm fluid in. Um, for your dirty instruments, typically what you're going to do, and what I mean by dirty instruments, this is at the end of the procedure. So these are the instruments that you actually used on that patient. But what you'll do is at the end of the procedure, all the ones you actually used, um, you will put into the basin and put, oh, sorry, one of the graduates who had to retake her test just texted me. I told her that she was going to get a 108 on that test. You need a 102 to pass. She got a 109. Woohoo! So, but in that basin, you're going to take all the instruments that you use, put them in there, and then you'll pour water in there uh, as kind of a cleaning process to keep the bioburden and all that stuff on it still wet, so that when it gets into decon, it's easier to clean. You may also have what's called a slush basin. Slush basin. It's an actual piece of equipment that's in the room. It looks like this big kind of square machine, and then it has its own little basin to it. And then we put a drape over the top of that, and then we'll pour cold water in there. And through the action, it'll cool it down and actually make ice and slush, right, is what we call it. And we use that in open hearts because we put that ice and stuff around the heart to get it to stop beating after we've put in all the cannulas and things like that, so that we can still perfuse and oxygenate the blood and send it around to the body. But in order to work on the heart, it's best if it's not beating and moving, right? Especially when we're trying to suture and things like that. But then on the flip side, you also have fluid warmers, things that can keep your fluids warm. Most often, you're going to be using those in like plastics, like kind of a reconstructive or a reimplantation of like a digit or something like that. That way, we constantly have warm saline and things because we're constantly flushing the incision site. And then, of course, any medication or fluid that gets put up on your field has to be labeled, right? We have to be able to know what's what, so that we're not accidentally injecting or using as an irrigant something that's going to damage tissue. And then completing your setup, right? This is all that secondary stuff, right? You prioritize setting up, your drapes and your gown and your gloves and your sponges and your sharps and that kind of stuff. You got it all, those first use things ready. And then now you can kind of tweak your setup and get it looking pretty, do your counts, right? Sharp sponges, instruments. Remember that we only have to count instruments if we're entering into a hollow organ or body cavity. Otherwise, it's just sharps and sponges. And then try not to handle your instruments once you're done with your setup. You're just done. You're just going to stand there and like hold your gown or hold your arms or something like that, waiting for the patient to be ready to be draped and for your doctor to be gown and gloved. You should stay in the room, right, and watch. Like let's say you just finished your setup. the nurse comes to you and says, hey, surgeon just called. They had to go see somebody down in the ER. We're delayed. Okay, you can break scrub. Right? You can take your gown and your gloves off, leave that the setup as it is. However, someone must be in the room watching those items. You cannot just like tape the door off or put up signs that say, hey, sterile stuff in here, don't touch or don't enter, that kind of stuff. Someone has to be in there watching, because if someone's not watching it, you don't know what could have happened. Somebody could have walked through that room not knowing there was open stuff set up without a mask on. Someone could have purposely, I don't know who could have, but people are people sometimes, a little weird, whatever, could have purposely gone in there and contaminated your setup, or thought that it was a canceled case and they go in and they just start tearing it down. The room can only be left like that with constantly being monitored for 2 hours before it has to be completely broken down and everything reopened and reset up. It's a weird rule. I've tried to argue this rule a few times because we have many, many surgeries that go longer than 2 hours. Yet we still have the same setup, the same instruments, all that kind of stuff. So the evidence behind it has never been fully explained well enough to me. So that's why I still kind of argue it, but I do know it's the rule, so I still follow it as the rule. If it's been 2 hours or longer, then you know I don't like it, and I'll complain about it the entire time I'm breaking it down. But I'm still breaking it down. All right, does anybody have any questions on this first part, like your setup and how to make it kind of more efficient, things like that? Okay, I'm going to pause it there, and then we'll get into like our procedures of counting and how to um, handle incorrect counts and things like that. Some of the things that we're looking for. Um, we'll talk a little bit about like your field management, things like that, when we get back into this. Let's see, there'll be a quiz next Monday over chapters 8 and 20. What else? What else? Keep working on those EALs. I have gotten a few of the papers graded. I'm working my way through those. So far, excellent job on those papers. Everybody, I don't think anyone has gotten less than 100 yet. So as long as you hit all those points that were in the assignment, you've talked about its trade name and generic names, and it's what it does and why we use it, what you learn, kind of stuff. And it's it's articulable, and I can read through it, and uh, I'm getting the gist of what you got out of it and stuff like that. Then all good. Um, if you missed any, discussion board or the workbook assignment or even the paper or anything like that, you got until Wednesday to get it turned in for a maximum of 75%. So um, I wouldn't take too many L's on assignments and discussion boards. You're going to find that it'll put you pretty much borderline, maybe even just under passing, uh, and then you're going to be fighting tooth and nail for every point you can get. So, and it's where the EALs can come in big for you too. So make sure you're working on those. Any other questions, comments, concerns? Oh, there we go. Ah, yes, there it is. You did. You remember now. I remember that now too. Um, so one of the things about, especially the breast biopsy surgery, is if you're working in an area that there's known cancer, you whatever instruments you use to remove that tissue, you do not want to use any of those instruments for the remainder of that procedure. Because once all the cancerous tissue is out, you can have some cancer cells on those instruments. You do not want to use them in the presence of the healthy stuff because you could be doing what's known as seeding the cancer. You're now introducing those cancer cells into a healthy area, and you could start the whole process over again of them having cancer there. So, um, like for very specific instance, when I am marking the specimen from the breast biopsy, and I'm using that needle and needle holder, when I go to close the skin, I should not be using the same needle holder that I use to mark the stitch or mark the specimen with. It should be a brand new needle holder because that needle holder that I use to mark the specimen could have cancer tissue or cancer cells on it, and I do not want to get them on the skin or in the tissue or in the wound at all. All right, guys. We will see groups B and C tomorrow in the lab. Be prepared to just do some procedures. For those of you I still need to catch up on some things on, we'll try and take care of those tomorrow while people are setting up and doing their things. Um, I believe Mr. Ortiz is back tomorrow, so be ready for some uh, loudness. He's just coming back from New York, so I'm sure it'll take him a minute to get that attitude back out.